Identify the posterior angle of the acromion and the coracoid process anteriorly. Mark entry point immediately below the posterior angle. Clean and firmly stretch skin. Rapidly insert needle perpendicularly. Angle slowly anteriorly towards coracoid. Aspirate and inject as a bolus. Locate the lateral border of the acromion and the spine of the scapula. Mark entry point 1/3 along the spine and 1 finger width superiorly. Clean and firmly stretch the skin and rapidly insert needle perpendicularly. Pass slowly down to bone of fossa and inject as a bolus around the nerve. Find the lateral aspect of the acromion. A thumb's width medially, feel for the step, which is the end of the clavicle. Mark entry point at joint line. Clean and firmly stretch the skin and rapidly insert needle perpendicularly. Angle slightly medially and inject as a bolus. Identify the top of the sternum. Move laterally until a small dent is found at the proximal end of the clavicle. Mark entry point at joint line. Clean and firmly stretch skin and rapidly insert needle perpendicularly. Angle upwards and medially, aspirate and inject as a bolus. Locate the midpoint of the lateral edge of the acromion. Mark entry point, clean and firmly stretch skin and rapidly insert needle perpendicularly. Angle slightly upwards and medially to slide slowly underneath the acromion. Aspirate and inject as a bolus while slowly withdrawing. The patient half lies with his arm behind back. Identify the anterior edge of the acromion, which lies in direct line with the lateral epicondyle. Palpate the tendon, which is approximately 1 finger wide, immediately in front of the acromion. Mark the entry point, clean and firmly stretch skin, and rapidly insert needle perpendicularly into tendon. Aspirate and pepper into the enthesis. Position patient with arm at 90 degrees of flexion, full adduction and full lateral rotation. Identify posterior angle of the acromion, which lies in direct line with the lateral epicondyle of the elbow. Palpate midpoint of tendon, approximately 2 fingers wide. Mark entry point, clean and firmly stretch skin, and rapidly insert needle perpendicularly into tendon. Aspirate and pepper into the enthesis. 3 areas can be injected from the front of the shoulder: subscapularis tendon, the bursa, and the shoulder capsule. Identify the coracoid process lying anteriorly and the lesser tuberosity on the humerus. Mark entry point immediately medial to this, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle laterally for the tendon, posterior for the bursa, or medially to enter the shoulder capsule. Locate the bicipital groove lying anteriorly between the greater tuberosity and the lesser. Mark entry point at top of groove, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle distally between tendon and sheath. Aspirate and inject as a bolus. Find the elbow joint line by feeling for a crease between the head of the radius and the humerus, and then flex elbow to about 45 degrees. Mark entry point, clean and firmly stretch skin, and rapidly insert needle perpendicularly just above the head of the radius. Aspirate and inject as a bolus. There may be swelling at the posterior aspect of the elbow. Mark midpoint, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Aspirate and deposit any excess fluid into containers, and then inject as a bolus. Identify the facet immediately in front of the lateral epicondyle. Mark entry point just medial to this, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle parallel to cubital crease and slowly pass down to gently touch the facet. Aspirate and pepper into the enthesis. Identify the medial epicondyle and the facet lying immediately in front of it. Mark entry point here, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Pass slowly downwards to gently touch the facet. Aspirate and pepper into the enthesis. The patient lies prone with the arm in the anatomical position. The humerus is fixed and the forearm is passively fully pronated. This brings the tuberosity posteriorly. Identify the line of the joint between the head of the radius and the humerus. Feel the radial tuberosity 1 thumb width distal. Mark this entry point, clean and firmly stretch the skin, and rapidly insert the needle perpendicularly down to touch bone. Aspirate and inject bursa as a bolus or pepper into tendon insertion. Place wrist in a slight degree of flexion and palpate the capitate-lunate joint line. Mark entry point, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Aspirate and inject different parts of the joint spaces as several boli. Place the wrist in slight radial deviation. Find the joint line distal to styloid process of the ulna. Mark entry point here, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Aspirate and inject as a bolus. Identify the gap at the base of the first metacarpal, which is at the apex of the snuff box, by opening and closing the joint. The patient extracts the thumb. Mark entry point, clean and firmly stretch skin, and rapidly insert needle perpendicularly into joint space. Aspirate and inject as a bolus. Palpate the joint line on the side of the finger. Mark clean and insert perpendicularly. Inject as a bolus. Identify the tendons by getting the patient to abduct the thumb. Feel for the space between the extensor pollicis brevis and abductor pollicis longus. Mark the entry point, clean and firmly stretch skin. Rapidly insert needle perpendicularly, angle proximally, and slide between tendons. Aspirate and inject as a bolus. Palpate the nodule at the base of the finger. Mark the entry point here, clean and firmly stretch skin. Rapidly insert the needle perpendicularly into the nodule. Aspirate and deposit a small amount here, then inject a remainder as bolus within the sheath. Identify the distal and proximal creases and palmaris longus if present. Mark entry point at the proximal crease, medial or lateral to the nerve, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle at 45 degrees and slide under retinaculum. Aspirate and inject as bolus. The patient is in side lying with upper leg extended and lower leg flexed. The upper leg rests on a pillow. Identify the greater trochanter posteriorly with one finger, anteriorly with thumb, and superiorly with the index finger, making a triangle with the 3 fingers. Place proximal index finger immediately above the superior point of the trochanter, while passively abducting the femur. This palpating finger should dip down about 2 fingers proximal to the trochanter, not on the bone. Mark entry point here, clean and firmly stretch skin. Rapidly insert a 3 to 4 inch spinal needle perpendicularly. Pass slowly down to gently touch neck of femur, aspirate and inject as a bolus. The patient is in side lying with upper leg flexed and lower leg extended. Palpate the tender area and mark epicenter. Clean and firmly stretch skin and rapidly insert a 3 to 4 inch spinal needle perpendicularly. Pass slowly down to gently touch blade of ilium. Aspirate and deliver injection in several boli, moving needle towards the surface as if walking up a spiral staircase. The patient lies supine. Identify the anterior superior spine on the ilium and the symphysis pubis. Midpoint between the two, find the femoral pulse. Place 3 fingers immediately lateral to the pulse, rotate round, and place the 3 fingers distally. Mark this point on the medial edge of sartorius. Clean and firmly stretch the skin and rapidly insert a 3 to 4 inch spinal needle perpendicularly. Angle the end of the syringe 45 degrees laterally and 45 degrees distally, and pass needle slowly down to gently touch neck of femur. Withdraw slightly, aspirate and inject as a bolus. Identify the epicenter of the tender area on the greater trochanter. Mark your entry point here, clean and firmly stretch skin. Rapidly insert needle perpendicularly to gently touch bone. Withdraw slightly, aspirate and inject as a bolus. The patient lies supine with the femur in lateral rotation and abduction. Identify the symphysis pubis and the tendons which are under tension and are approximately 2 fingers wide at the origin. Mark the entry point here, clean and firmly stretch the skin, and rapidly insert the needle perpendicularly. Angle slowly towards the symphysis pubis and gently touch bone. Aspirate and pepper into the enthesis. The patient lies on the unaffected side with lower leg extended and upper leg flexed. Identify ischial tuberosity and immediately distally palpate the wide band of the origin of the hamstring tendons. Mark entry point here, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle upwards to gently touch bone. Aspirate and pepper into the enthesis or inject ischial bursa as a bolus. Identify the anterior superior iliac spine and move immediately distal. An area of tenderness is usually found about a hand's width below the spine. Mark the entry point here, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Pass needle slowly down into quadriceps muscle. If a burning sensation is felt, reposition, aspirate, and inject solution as a bolus around the nerve. The knee joint can be injected from many directions, but a safe and convenient way is medially between the condyle and the patella. The patient sits with knee slightly flexed. Push the patella medially with the thumb and identify the gap immediately below the medial edge of the patella. Mark entry point here, clean and firmly stretch the skin, and rapidly insert needle perpendicularly. Angle up underneath the patella, aspirate, and inject as a bolus. The joint line runs at an oblique angle and the entry point lies on the anterior aspect. Please note, we never inject in the presence of an open wound. Find the joint line by gliding the fibula on the tibia. Mark the entry point here, clean and firmly stretch the skin, and rapidly insert the needle perpendicularly. Angle upwards and laterally to penetrate the joint space. Aspirate and inject as a bolus. Place the knee at 90 degrees with the foot rotated laterally. The tibial plateau is then brought forward and the ligament lies along the medial margin. Mark entry point here, clean and firmly stretch the skin, and rapidly insert the needle perpendicularly. Angle down onto the rim of the tibial plateau. Aspirate and pepper into the ligament. The medial collateral ligament runs in a broad band from above the medial condyle, inserting low down on the tibia. It is usually affected along the joint line. Mark the entry point at the tender area, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Aspirate and pepper into the ligament, taking care not to enter the joint space. The bursa lies immediately deep to the infrapatellar tendon. The tender area is usually at midpoint of the tendon, which is approximately 2 fingers wide. Mark the entry point at the edge of the tendon, clean and firmly stretch the skin, and rapidly insert the needle perpendicularly. Pass behind the tendon to approximately midpoint, taking care not to enter into it. Aspirate and inject as a bolus. The bursa lies on the medial side of the knee and is identified by resisting knee flexion strongly while palpating the 3 medial hamstring tendons until they disappear on the edge of the tibia to form the pes anserinus. Immediately proximal and deep to this is the tender area of the bursa. Mark entry point here, clean and firmly stretch the skin, and rapidly insert needle perpendicularly. Pass slowly down to gently touch bone. Withdraw slightly, aspirate, and inject as a bolus. The bursa lies immediately below the distal end of the band. Palpate for tenderness and mark the entry point at epicenter. Clean and firmly stretch skin and rapidly insert needle perpendicularly. Pass needle down to gently touch bone. Withdraw slightly, aspirate, and inject as a bolus. The expansion is usually strained on the medial side at the superior pole of the patella. Push patella medially and hold it in place. Palpation identifies the extent of the tender area. Mark entry point here. Clean and firmly stretch the skin and rapidly insert needle perpendicularly. Pepper along the edge of the patella, avoiding entering the knee joint. The tendon arises from the inferior pole and is about 2 fingers wide. It's usually affected at its origin, which is found by depressing the superior pole downwards to make the inferior pole prominent. Identify the edge of the bone, mark entry point here, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle upwards to touch the rim of the patella. Pepper around the rim in both directions. The Baker's cyst lies in the popliteal fossa at the back of the knee. Identify midpoint of the fossa, move 2 fingers medially and 2 fingers distally. Mark entry point here, clean and firmly stretch the skin, and rapidly insert a large bore needle with a large syringe perpendicularly. Angle up and laterally so the needle slides anterior to the popliteal vessels. Slowly aspirate and dispose of fluid into containers for culture and disposal. Identify a triangular sulcus at the top of the talus between the inferior border of the lateral malleolus and the tibia. Mark entry point here, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle slowly upwards and medially to go over the top of the talus into the joint space. Aspirate and inject as a bolus. Palpate the sustentaculum tali, which lies immediately below the medial malleolus. Just posteriorly and slightly above is a small gap which is identified by tilting the talus. Mark the entry point here, clean and firmly stretch the skin, and rapidly insert the needle perpendicularly into the joint space. Aspirate and inject half the solution here. Slightly remove needle and angle anteriorly to pass through the septum that divides the joint. Inject remaining fluid as a bolus. The ligament arises from the medial malleolus and fans distally. It is usually affected at its origin. Mark the entry point at the centre of the tender area, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle upwards to gently touch the malleolus. Aspirate and pepper around the origin. The ligament runs from the antero-inferior aspect of the lateral malleolus to the top of the talus. It is approximately the width of the little finger and runs parallel to the sole of the foot. Mark the entry point at the centre of the ligament, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle upwards to gently touch bone of the lateral malleolus. Aspirate and pepper half the solution along the malleolus, then turn needle subcutaneously down towards the talus, gently touching bone, and pepper the remaining fluid here. The patient lies prone with foot strongly dorsiflexed against the injector's thigh. Identify and mark the centre of the tender area. Clean and firmly stretch the skin on one side of the tendon and rapidly insert the needle perpendicularly. Without entering the tendon, angle needle proximally so that it slides under the skin to its full length. Aspirate and inject half the solution as a bolus while withdrawing the needle. Repeat the procedure on the other side. The bursa is found in the triangle immediately anterior to the tendon. The safest approach is from the lateral side, avoiding posterior tibial vessels which lie on the medial side. Mark the entry point, clean and firmly stretch skin, and rapidly insert needle perpendicularly just in front of the tendon. Aspirate and inject as a bolus. Identify the joint line by palpation and by gliding the two bones. Mark the entry point at this joint line, clean and firmly stretch the skin, and rapidly insert needle perpendicularly into joint space. Aspirate and inject as a bolus. Find the joint line by extending and flexing the toe. Apply distraction and mark the entry point. Clean and firmly stretch skin and rapidly insert the needle perpendicularly into the joint space. If it does not enter straight away, flex the toe a little more and move the needle about until it is within the space. Aspirate and inject as a bolus. Ask the patient to evert the foot and palpate the small gap between the brevis and longus tendons. Mark the entry point here, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle subcutaneously so that the needle tip lies between the two tendons. Aspirate and inject as a bolus within the sheath. Palpate the tender area invariably found on the medial side of the calcaneum. Do not inject through the heel pad, but move distally to the edge of the pad where soft area of sole begins. Mark entry point here, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Slowly angle needle proximately at about 45 degrees until the point gently touches bone. Pepper along the enthesis. The patient is in side lying with the neck in flexion and side flexion away from the painful side. Identify the spinous processes and the tender facet joint. Mark the entry point, one finger distal to this joint. Clean and firmly stretch the skin and rapidly insert needle perpendicularly. Angle slowly proximally at about 30 degrees. Once needle tip gently touches bone of the facet, aspirate and inject in or around the joint as a bolus. Keep the needle parallel to the spinous processes at all times and do not angle medially. Feel the spinous processes. Approximately 2 fingers lateral lies the lumbar facet joint. Mark entry point, clean and firmly stretch skin, and rapidly insert a 3 to 4 inch spinal needle perpendicularly. Pass needle down to gently touch bone. Aspirate and inject in or around the facet joint as a bolus. Palpate the posterior superior spines on the ilium. An equilateral triangle has its apex at the base of the sacrum, just above the buttock cleft. Identify the 2 sacral cornua and mark entry point just distal to this. Clean and firmly stretch skin and rapidly insert needle perpendicularly. Angle proximally at about 45 degrees, although this is very variable. The needle may have to be changed several times to ensure that it passes through the sacral hiatus and slides a short distance slowly into the canal. Aspirate to ensure no cerebrospinal fluid or blood is present, and then inject slowly as a bolus. Feel the posterior superior spine on the affected side. Mark entry point about a thumb width medial and a thumb width distal. Clean and firmly stretch skin and rapidly insert needle perpendicularly. Angle 45 degrees obliquely upwards and laterally, entering through the posterior ligament into the joint. The angle varies with different body shapes. Aspirate and inject as a bolus. Identify the sacral cornua, the 2 little bumps just above the buttock cleft. Move distally to the sacrococcygeal joint line. Mark the entry point, clean and firmly stretch the skin, and rapidly insert needle perpendicularly. pass down to gently touch bone. Aspirate and pepper around the ligamentous attachments. The patient is inside lying and opens and closes the jaw, so the bump of the mandible can be felt rolling forwards. The patient keeps the jaw open. Mark the entry point just anterior to the mandible, clean and firmly stretch the skin, and rapidly insert needle perpendicularly. Pass needle into joint space, aspirate and inject as a bolus. The bony landmarks are the posterior angle of the acromion and the coracoid process lying anteriorly. The needle is inserted immediately below the acromion and aimed towards the coracoid, ending at the glenoid within the joint space. The bursa lies under the acromial arch and is variable in size. Bony landmarks are the posterior angle and the anterior angle of the acromion. Just below the midpoint of the lateral edge of the acromion is the entry point for the needle, which is then angled slightly upwards and medially to its full length to enter the bursa. The suprascapular nerve lies in the fossa, and the needle point must touch bone before injecting. The tendon arises from the facet immediately in front of the lateral epicondyle. The needle is inserted just anterior to this point, moving down to touch the facet and pepper the solution at the tendon enthesis. The tendon arises from the facet lying immediately in front of the medial epicondyle. The needle is inserted just anterior to the facet and passes down to touch bone. The solution is peppered into the enthesis. The tendon runs anteriorly and attaches into the styloid process on the radius. The patient lies prone with humerus fixed in neutral and wrist fully pronated, bringing the styloid process posteriorly. It is then accessible to the needle and away from the major anterior vessels. Identify the edge of the ulnar and joint line between the humerus and the head of the radius. The styloid process is about 1 thumb's width distal. The needle is inserted here down to touch bone. Identify the edge of the metacarpal on the radial border and the trapezium immediately proximally. Feel for the gap by opening and closing the joint space, and insert needle perpendicularly into this space. Identify the greater trochanter. A good 2 fingers proximal to this lies the slope of the upper part of the trochanter. A long spinal needle inserted immediately proximally will pass down to touch the neck of femur. The needle tip will then lie within the capsule. Palpate the medial border of the patella. The needle is inserted and angles slightly upwards to enter the joint space behind the patella. Find the joint line which runs obliquely under the lateral shelf of the tibia. The injection is given by entering the joint space anteriorly and angling slightly upwards and laterally. The safest and easiest point to inject the ankle joint is on the lateral aspect. Passively plantar and dorsiflex the foot and identify the small triangular sulcus on the anterolateral aspect of the joint. Insert needle and move upwards and medially to enter the joint space. Identify the medial malleolus and move down to the sustentaculum talus. Immediately above and slightly posterior is a sulcus. Insert needle into posterior section of the joint. then pass anteriorly through the septum into the front of the joint. Palpate the joint line by opening and closing the joint. The needle is inserted perpendicularly down into the joint space. The joint line is identified by opening and closing the joint. Traction is then applied and the needle inserted into the joint space, avoiding the extensor hallucis tendon. Identify the tender facet joint lying about 1 finger lateral to the spinous process. The needle enters at an angle of about 30 degrees. Localize the spinous process and the interspace between the two. 2 fingers laterally marks a point over the facet joint. A long spinal needle will pass down to touch bone at the back of the facet. To find the sacral hiatus, first identify the 2 posterior spines on the sacrum. The sacral cornua lie at the apex of an equilateral triangle. Feel for the sacral hiatus in the space between the cornua. A needle inserted at this point and angled upward a short distance will pass through the ligament and lie within the end of the canal. Localize the posterior spine on the affected side of the sacrum. Move about a thumb's width medial and a thumb's width distal. A needle inserted at this point and angled obliquely upwards and laterally through the posterior ligaments will enter the joint space. The patient is examined, diagnosis made and informed consent obtained. He is placed in a half-lying position, comfortably supported, with the arm hanging over the side of the plinth. First prepare the equipment. Assemble sterile wipes, cotton wool and plaster. Prepare a 5 ml syringe, a drawing up needle and a 23 or 21 gauge 1 1/4 or 1 1/2 inch needle. Select a 1 ml vial of a medium-acting corticosteroid. In this case, Kenalog 40 is used. And 2 ampules of 1% local anaesthetic, lidocaine in this instance. Check drug names, doses and expiry dates. Palpate the posterior angle, the anterior angle and the lateral border of the acromion. Using a sterile needle guard, identify the midpoint of the lateral border. Stretch skin very tightly and press there firmly. A small circle marks the entry point for the needle. Clean the skin using a spiraling action and then thoroughly wash the hands. Gloves may be worn but are not mandatory in Britain. Draw up 30 to 40 milligrams of corticosteroid, mixed with 4 ml of 1% local anaesthetic. Stabilize the injecting hand close to the site, stretch skin firmly and rapidly insert needle perpendicularly. Slowly angle upwards under the acromion. Aspirate, then inject solution while slowly withdrawing. Press firmly around needle with cotton wool and rapidly remove. Dispose of syringe and needle safely in Sharps box. Position the patient with the elbow at right angles and forearm supinated. Palpate the facet on the lateral epicondyle, and the entry point immediately anterior is marked and cleaned. Use a 1 ml syringe containing 10 milligrams of steroid and 3/4 ml of 2% local anaesthetic, and attach a 25 gauge half-inch needle. Fix the injecting hand, firmly stretch skin, and rapidly insert needle perpendicularly. Subcutaneously angle down to gently touch the facet, aspirate, and then pepper the solution by depositing 8 to 10 droplets within the tendon at the enthesis. When the syringe is empty, press cotton wool firmly around the needle and rapidly remove. Dispose of syringe and needle safely into Sharps box.